191 is the name of the monoclonal antibody that we have developed in my laboratory and actually as part of my disease team. 191 was previously made by a biotech company with a different idea for its use. But we know that the target of 191, which is called CD117 or c-KIT, is a molecule that's expressed on stem cells, and that it's important, the interaction between c-KIT and stem cell factor is important for stem cell survival, right? So when we think about the use of 191, we sort of have to step back and think about, well, why would it be useful in transplantation? So in blood stem cell transplantation, what we're really doing, it's replacement therapy, where we want to eliminate the recipient's blood stem cells because they're not making blood appropriately, with that of a donor or gene-corrected stem cells. And in order to do that clinically, right now, clinicians are just faced with using chemotherapy. And that chemotherapy has off-target toxicities. It's DNA-damaging chemotherapy, basically. And so there's off-target toxicities that kill the stem cells, but there's other side effects as well, both acute and chronic. And so what 191 is it targets now specifically the stem cells of the recipient. Again, the recipient stem cells won't leave voluntarily, even if you put other stem cells in. You have to get them out of these specialized niches in the bone marrow. So what 191 can do is replace the chemotherapy that's used to empty those bone marrow niches, target the stem cells specifically and safely, and then allow for the incoming donor cells to engraft. So in the setting of SCID, SCID is kind of the, is really a really ideal disease. Those kids, they don't make lymphocytes, so they can't reject the incoming cells, but they still need to have the niche space cleared. We still need to make space for the incoming hematopoietic stem cells. And we also know that in the SCID kids, some of the genotypes in SCID are really sensitive to DNA damage. They're actually, that's part of their mutation. And so if you give them chemotherapy, that's really a population that's really at risk for the complications. But so with the 191, right, we're able to then reduce those complications, safely target the stem cells, get the graft in, and then the patients engraft. So I think that this, again, I think the important point about 191 is it's actually the first biologic, the first antibody to be able to replace chemotherapy as part of this aspect of hematopoietic cell transplantation. I think that in the SCID kids, it's really, it's really the proof of concept that the antibody does what we think it would do. It did in mice, and now we're seeing that it's working in humans in the same way as a great target for depleting stem cells safely. But this principle goes across to all diseases for which transplant is indicated, of which there are many. So again, this is the proof of concept that targeting with an antibody can work to deplete stem cells and allow engraftment. But it's going to be applicable to the many other diseases, including non-malignant diseases like the hemoglobinopathies, sickle cell anemia, thalassemia, and also for patients that have leukemias and myelodysplastic syndrome, because we know that this antibody also targets those stem cells. We're in the phase of the study now that we're doing a dose finding of the optimal dose to be able to use to deplete the stem cells and get optimal engraftment. We actually started with older kids with SCID who had a prior transplant, but those prior transplants failed. And so we went to those children and young adults and tried the antibody and see if we can get their donor cells to really engraft with true stem cells. So when I say that the transplant failed, it means that they were able to make lymphocytes and T cells, but they never really engrafted with true stem cells. So they weren't making B lymphocytes, and the T cell function sort of petered out over time. They really lost the ability to make new T cells. So those children now we're working to find the optimal dose, and then we're expanding to a phase 2. And then with us showing the safety and efficacy in the older kids, that's why we've opened the study now to the newly diagnosed infants for transplant.